Hello, my name is Atul Deodhar. I'm a professor of medicine at Oregon Health and Science University in Portland, Oregon. My research interest is in axial spondyloarthritis and psoriatic arthritis. And today I'm joined here by Dr. Mohamad Bittar, who is also an assistant professor at Oregon Health and Science University. Dr. Bittar's research is very novel. And this is a big trend that actually I'm noticing in this particular conference as well. And that's why I thought I will bring him here to discuss his research. But just in short, what we are finding is that nowadays in inflammatory arthritis, axial spondyloarthritis included, the morbidity is not because of the inflammation. We are pretty good at controlling the inflammation of our patients with our biologics. Leftover pain, leftover fatigue is the reason why people are becoming disabled. And so Dr. Bittar has some very novel research ideas. He had a poster here. He also was chairing a session on this particular entity of leftover pain. So Dr. Bittar, take it from here. Tell us a little bit more about this leftover pain and how can we measure it and what can we do about it?
Thank you so much for having me, and this is an extremely important topic that has been neglected in rheumatology. As you mentioned, we always focus on treating inflammation, but we forget about the leftover pain, which is driving the patient's disability and the symptom and the burden of the disease. And that's why it's time for us to focus on studying pain in rheumatic diseases. So I'm very happy to share that in this conference at the ACR, we've seen a lot of new work on pain in rheumatic diseases, whether in rheumatoid arthritis, in psoriatic arthritis, and of course in axial spondyloarthritis, our research interest. I can talk to you a little bit about the project that we've done, is where we're trying to look into the brain imaging and the CNS, central nervous system dysregulation in patients who have axial spondyloarthritis, because this can explain why patients continue to have chronic pain without having inflammation. So in particular, we're interested in looking the resting state connectivity on how different parts in the brain connect to each other, and also how the brain responds to a painful stimulus. So for example, the project that we've done on AxSpA patients, it showed that AxSpA patients respond differently to a painful stimuli compared to healthy controls. For example, mainly we got two signals from the default mode network and the salience network. Default mode network, it usually is active when we are in a relaxed state. Whenever we get an input or an insult, this should be inactivated. Our study showed that in patients who have AxSpA, actually default mode network got activated, which is abnormal. That means patients are focusing on, the brain is focusing on pain, and that's why they go into a chronic pain state. Also, the salience network, it got exaggerated responses in AxSpA. Salience network. Okay. In AxSpA compared to healthy controls. So we got signals that different parts of the brain are working differently in AxSpA patients who have chronic pain.
Yeah. So there were some abstracts yesterday, and you are chairing that one session, where some similar work has been done also in rheumatoid arthritis and in psoriatic arthritis. Do you want to tell us about that?
Definitely. And there was a very interesting oral abstract that was presenting yesterday on rheumatoid arthritis, where patients had, I believe it was 27 patients who had functional imaging of the brain, and a task was an input or a painful stimulus was done on rheumatoid patients in the wrist, and it showed activity in the insula in the brain, which is part of the salience network. Similarly, there is another session on psoriatic arthritis, but this was mainly on fatigue, and it showed that insula played a role in it. So we are seeing different mechanisms that are non-inflammatory playing a role in rheumatoid, in PSA, in AxSpA. So we need to start looking at these pathways.
Yeah, this is going forward. We are going to be looking at more and more research as well as abstracts at annual meetings. And we will hopefully one day find the differences of how the brain works with nociceptive and nociplastic and neuropathic. Those are the three different types of pain, which parts of the brain get activated, and how we can intervene to prevent this. I think this is something that I would suggest the viewers should be aware of and keep an eye on. This is a very exciting new area in the field of rheumatology.